Dear all, today we are going to talk about one of the multiple gray areas in the management of bone sarcoma. We will try to focus on joint involvement in tumors around the knee. This is a 45 years old male who presented with a 3 months history of right knee pain. X-rays showed a metaphyseal osteolysis in the lateral condyle with ill-defined margins, given a mouth-eaten aspect, destroying the cortical bone with periosteal reaction. These are features of an aggressive lesion. The two main malignant bone tumors in the adult are chondrosarcoma, but here we don't have characteristic calcifications. The second tumor is a malignant fibrous histiocytoma. Less commonly we can observe in the adults osteosarcoma. The MRI showed a metaphysio-epiphyseal intramedullary lesion destroying the cortical bone, extending largely to surrounding soft tissues, mainly anteriorly and laterally. The tumor is far from neurovascular bundles, however, it seems to be intra-articular. Biopsy revealed the proliferation of spindle cells which are frankly malignant. There was neither osteoid production nor chondroid matrix. The positivity to vimentin confirmed the sarcomatous origin of the proliferation, and the negativity to Candlesmon eliminates muscular differentiation of the tumor cells. These features are compatible with the diagnosis of malignant fibrous histiocytoma or MFH. So to sum up, we have an MFH of the distal femur localized in the lateral condyle, which is highly suspected to be intra-articular with no distant metastasis. So what are the therapeutical options? Treatment of MFH is surgery with a wide resection as a goal. Here in this particular case, two technical problems need to be resolved. First of all, which approach should we use for the resection? Since the lesion is in the lateral condyle, should we use the medial or the lateral approach? The second question is what to do to achieve safe margins. Should we perform an extra-articular resection as suggested by MRI, or intra-articular resection will be sufficient? Malignant fibrous histiocytoma is a high-grade sarcoma, so chemotherapy is recommended as adjuvant post-operatively. In this case, we performed a resection through a lateral approach since the tumor is developed in the lateral condyle. This was also the approach for the biopsy, and we have done an intra-articular resection of the distal femur. As you see here, the tumor was covered by fat and synovium. Macro section, we see the extension of the tumor laterally, but it remains separated from the articular joint by synovium. This was confirmed by histology, which showed a healthy tissue covering the tumor. Although thin, this layer of synovium is an anatomical barrier covering the tumor, and so our margins were safe. Used omega prosthesis for the reconstruction of the distal femur, and this is the functional result 1 month postoperatively. A resection of the distal femur is commonly performed through a medial approach, but it can be done through a lateral approach as well, especially when the tumor is developed in the lateral condyle. The principal advantage of this approach is that we can preserve the vastus medialis, which is the principal head of the quadriceps. Currently, MRI is the best mean for the evaluation of local extension of bone tumors. However, it's not accurate to definitely confirm or exclude synovial joint involvement. We have presented in 2009 during the ISOLS meeting a communication about the assessment of joint involvement in bone sarcoma around the knee. Our study showed that the sensitivity of MRI was 100%, but the specificity was only 41%. So if we rely on MRI, we'll perform about 60% of unnecessary extra-articular resections, which are technically more demanding and with poorer functional result. In our study, we have identified three main patterns of joint involvement in tumors of the distal femur. The first pattern was anteriorly, and MRI showed usually an extension of the tumor mass into the joint space through the suprapatellar bursa. But what we don't clearly see on MRI is that the tumor remains covered by a layer of fat and synovium as depicted here on macrosection. Here the tumor pushes the boundaries of the synovium inside the joint space without infiltrating it. Histology confirmed that the tumor was separated from the joint space by this layer of synovium. Articular cartilage is also a barrier against the tumor invasion of the joint space. But when we look carefully in the junction between synovium and cartilage, we find that the tumor tissue is developing in between, and this is the weak point of the joint. The second pattern is the development of the tumor in the lateral sides of the condyles, and as we see here on MRI, we can say that the tumor seems to be obviously intra-articular. But here also the tumor is intra-articular but remains extra-synovial, so a resection of the epiphysis here gives safe margins. The third pattern that we have observed is the extension of the tumor in the joint space through the intercondylar notch as shown here on MRI. Once again, the tumor remains extra-synovial and there is no need to perform extra-articular resection. So, what are the rules if MRI shows involvement of the articular space? Actually, there is no evidence from the literature, which is very scarce about this problem. All what we know is that articular invasion by a tumor is a rare and late event, and what we learned from discussion with the experts in orthopedic oncology, and as you know this is the lowest level of evidence, is that in suspicious cases it is advisable to perform an intra-articular assessment of the joint through an arthrotomy before to decide whether to perform an extra or an intra-articular resection. In conclusion, MRI is a valuable tool for the evaluation and staging of bone tumors. However, it has a low specificity in the assessment of articular involvement. Our study showed that the extension of the tumor inside the joint space has a pushing pattern towards synovium, but we don't know what are the limits of this pattern. So more studies are needed to better illuminate this gray area. Thank you for your attention, and I'm looking forward to hearing from you because we really need to share experience. Bye bye.